I always forget that. Okay, we are recording now. I am Janelle Komorowski. I'm the faculty advisor for the Frontier Nursing University chapter of the IHI Open School. And we are thrilled today to be able to bring you this presentation about promoting respect in maternity care through shared decision making. And as part of this, we're doing this jointly with the Right Care Alliance Women's Council. And Dr. Judy Butler is here with us. She is my co-chair for that committee that we're on. And Judy, do you want to say anything?
Just welcome to all of these wonderful students and people from everywhere that have come, and we're just really super excited. So thank you so much for participating, everybody.
And we also are very glad to welcome Stephanie Ains of the Right Care Alliance, and I'm going to give her just a couple minutes before I introduce our speaker to tell you a little bit about Right Care Alliance, what it does, and how you can get involved.
Great, thanks so much. Hi, everybody. It's great to be here and see some familiar names. I wish I could say faces, but names is good enough if we can't all see each other. So I am also really looking forward to this conversation and very happy that we could all hold this event together. For those of you who don't know, the Right Care Alliance is a grassroots coalition of clinicians and patient advocates all coming together to fight corruption in healthcare, to fight medical overuse and underuse. We have chapters who are organizing around drug prices, especially around insulin prices, making sure that people with type 1 diabetes can afford the insulin that they need to survive. So we have chapters who are working on that, who do that through protests, educational events, pushing for legislation in their states and cities. And then we also have the councils, such as the Women's Health Council, which are groups that are organized by healthcare interest area. Besides the Women's Health Council, there's a patient engagement, primary care, behavioral health, topics like that. And the different councils all work on projects to focus on how to, again, fight against overuse, also make sure that people have access to care within their world. And so we are hoping to do more and more events like this with the Women's Health Council, other webinars like this, possibly writing events where we get together and write op-eds about different topics within women's health, share and learn together. And so this is the first women's health event like this of the year, but we're hoping to do so many more, hopefully some in collaboration and some not. So please get involved. I'm going to put in the chat ways to get involved. Yes, I see Amanda's cheering in solidarity for insulin prices. That's great. So I am really looking forward to this. And again, I'll put in chat how folks can stay involved in Right Care Alliance activities.
Thank you very much, Stephanie. And I hope that many of you students will consider getting involved, because it's really exciting what the Right Care Alliance is accomplishing. And now I am really happy to introduce Michele Megregian. She is Clinical Assistant Professor at Oregon Health and Science University, School of Nursing, Nurse-Midwifery Academic Program, and she practices full scope midwifery with the faculty there. She completed a fellowship in interprofessional healthcare ethics at the Center for Ethics in Healthcare at Oregon Health and Science University, and she has a certificate in medical ethics from Portland State University. She's also currently enrolled in the PhD program in ethics at, I may butcher this name, Maastricht University in Netherlands, exploring shared decision-making and ethics education for midwifery students. So we'd like to extend a warm welcome to Michele.
Hi, everybody. Thank you so much for this invitation and this opportunity to talk with you all. For those who are coming in late, please excuse me. I am post-call and drinking coffee, so that's why I did not have an opportunity nor did I realize that we were going to be on video, so this is all good. So we're going to talk a little bit about shared decision-making and some of the newer kind of articles that have come out around obstetric violence, for lack of a better phrase, and kind of mistreatment of women in maternity care. I would love, as people have questions, if they want to put it in the chat, I'm happy to kind of go through and answer those questions as we talk. Feel free, Janelle and Judith, to just kind of interrupt me as needed if you have a question or want me to stop and kind of go back through something. Especially if as I drink my coffee, I'm talking a little bit too fast for everybody. So that being said, let's see if, go to the next, oops. There we go. So I have no disclosures about anything. I am living currently in Eugene, Oregon. This is a picture of the Oregon coast around Cannon Beach, which is one of the most beautiful places, I think, on the planet. My personal bias. So just a couple of objectives for our talk today, just becoming familiar with shared decision-making, talking about decision aids and shared decision-making, some resources, and then understanding some current concerns about obstetric violence and disrespect in maternity care. So I don't know what you all have seen in the news over the past couple of years, but I think in this decade, it really started to become more in the public consciousness about mistreatment on the obstetric floors for women with the CBC expose, so to speak, in 2016. I don't know if any of you are on the maternity care listserv from Canada, but there was a lot of discussion about this news article that came out online and this investigation about mistreatment of women in obstetric care and in the delivery rooms and labor and delivery units. This one is an article from 2018, again, just talking about how women have been reporting more and more about what's been happening to them and the treatment that they receive on obstetric floors. And in 2012, the World Health Organization put out a statement about the use of the physical abuse and abuse in language and disrespect that women experience internationally, and the call for how do we correct that. But I think for anybody who's in this field, this is really, unfortunately, not surprising and not new information for anyone. This is a PubMed count that I did just a few days ago to kind of in preparation for this, and just to see kind of like what's happened over the past few years with articles that have been written about obstetric violence. And you can see it starts in 1951, the first article about obstetric violence, which was in a French local obstetrician's newsletter. And it was entitled "Violence in the Course of Labor or Obstetrics Improved by Intelligence and Reason," which I fortunately wasn't able to get my hands on that actual article. And you can really see that in every decade, there's been about, some awareness that has come up where articles are written. And then really, you can see in 2016, after the CBC expose, is really when in the medical literature and our literature, the number of publications has certainly skyrocketed. Now, again, remember that the title of that CBC, we'll be getting to examples in a second. The title of the CBC article was "Mistreatment in the Delivery Room." What I don't have here is a picture for you. In 1958, the Ladies' Home Journal published an article called "Cruelty in the Maternity Wards." And that really helped spur the childbirth education movement of that time, starting with Grantley Dick Reed and Childbirth Without Fear. That, along with the feminist movement, has really changed, in some ways, how we see women in obstetrics and how we treat them. But again, like I said, all of us who are in this know that this is not a new thing. And unfortunately, it's an ongoing thing. And that can be even why we are in this field to begin with. So in 2016, this is to me the most accurate and understandable definition of obstetric violence, which really talks about it in a human rights perspective. So the right to non-discrimination, the right to security, the right to reproductive health and autonomy, and freedom from disrespect, cruelty, and degrading treatment. Before that, in 2015, they published an article, on global mistreatment of women in maternity facilities, and kind of categorize them into these types. So they're talking about physical abuse, which is not just kind of doing vaginal exams without women's consent, which I would consider that, but also slapping, also forcing women's knees apart. I have been, for part of my PhD project, I interviewed students who related some of these things happening on the labor floor even now. This was last year, where a student recounted having to hold a woman's legs apart as she delivered, and not really realizing or not quite aware of how violent that is, that's a type of mistreatment. Of course, sexual abuse or sexualized language or sexualization of any actions in the labor floor, verbal abuse, coercive language. How many times have we heard a provider say, well, if you don't do this, your baby's going to die? Any sort of stigma or discrimination. So discrimination based on ethnicity, race, religion, gender identity, HIV status, failure to meet our professional standards. So not obtaining informed consent, or even much less shared decision-making, which we'll talk about, refusal to provide pain relief, so she deserved it, or it's not I don't think she needs it, or just being abandoned by their providers. They include in this, which I find interesting, ineffective communication. So the inability to create a respectful rapport with women or in the labor floor, which then proceeds to their loss of autonomy. And here's where I think shared decision-making can really make a difference. And then, of course, the larger health system issues, which is lack of resources, lack of staffing. So, for example, women who are unable to obtain a VBAC because it is not available in their system due to whatever systems they have put into place, they identify that as a type of mistreatment. In 2018, I don't know if you guys saw this in the journal Birth, Morton published their survey of doulas and nurses. The survey was done in 2013, 2014, and they had a little over 2,700 doulas and nurses who reported witnessing disrespectful care. And really what they said was about a third reported it as occasionally or often that they witnessed a care provider threatening a woman that her baby might die if they didn't submit to a procedure, be it whatever, a C-section, AROM, whatever they thought. 65% reported they had witnessed providers occasionally or often engaging in procedures without fully giving women an opportunity to consider their options. And 18% reported witnessing providers occasionally or often engaging in procedures explicitly against the patient's wishes, which some would consider assault. I want to take a moment to talk about listening to mothers, just because this has really been in the United States how we have gained knowledge about women's perspectives, about their ideas of informed consent and how much they've participated. And in the first Listen to Mothers 1 came out in 2002. And their question really asked about being informed. So in that one in 2002, about 1 in 3 women had limited or no understanding of their right to information about certain procedures. In 2005, which with Listen to Mothers 2, they asked a little bit more detailed questions about informed consent, and they said that most women had an understanding of their right to understand or their right to information about procedures, but they made a specific example of only 18% of women who received an episiotomy remembered giving consent for that episiotomy. 18%, less than 1 in 5, which is crazy. And then in 2013 is really when shared decision-making came in to listening to mothers. So they've specifically asked about shared decision-making in the context of VBAC and induction of labor for macrosomia. And in that, in their analysis of women who had spoken with their providers about a possible... Now. Are we good? Okay, thumbs up. Communicating with women about induction of labor, specifically for macrosomia. Of those women who were induced, about 80% felt the decision was a shared decision, but 80% of those women also said that their doctor recommended the intervention. So really, are we actually doing shared decision-making in the way that we think we are? So that brings me to talk about shared decision making, because I really think that shared decision making has an opportunity to mitigate some of the effects of what we see as obstetric violence. But we have to understand what it is, and we have to understand what it isn't in order to really be effective with it. So shared decision making, the most accurate definition, and the one that most people use in the literature, is coming from 2012, the National Academy for State Health Policy, and they describe it as a process. So that's a key component of this, is that it's an ongoing process that is under continual evaluation. It's between your provider and a patient with a preference-sensitive condition, which I'll explain in a moment, in order to help the patient decide among multiple options which option is they should choose that's in accordance with their values and preferences and goals. So there's really three components to shared decision making. You've got three things happening here. You've got a patient, and the patient needs to be a clinically appropriate patient for this particular intervention. You have a decision aid, which is more than just an information pamphlet, which we'll get into. And you've got a condition. You have a decision that needs to be made, or an intervention that needs to happen. The emphasis on this is coming from the ideas of patient autonomy and an emphasis on this process and the relationship between the provider and the patient, or the provider and the woman. Just to give you some background, since I am a philosophy major, and I do always go back to the kind of original, where did this really come from? The shared decision making kind of really came out of, and the same with this idea around the moving away from a paternalistic model to a shared model, or a consumer model. So it came out of the consumer rights movement. It came out of the research and legal arenas in terms of defining, informed consent and what informed consent really means. It's come out of the movement in medicine from treating diseases to looking at more prevention and evidence-based medicine. And the Picker Institute in 1988 is really credited with providing the first definition of patient-centered care in terms of quality in healthcare. But I just like to point out that really the first one was this nurse in 1952 in the American Journal of Nursing, who published an article about planning patient-centered care, which is creating an individual plan to ensure safety and continuity, which is exactly what we're talking about in terms of patient-centered care. So the popularity of shared decision-making kind of increased over the 2000s into the 2010s, and it's been in legislation. So Washington State has written in its administrative code that a defined version of informed consent, which includes shared decision-making with a decision aid, which if a patient has received a decision aid, a provider documents about shared decision-making, that is evidence of informed consent. There was an international statement on shared decision-making in 2010. When the original Affordable Care Act came out in 2010, there's a section on creating, validating decision aids for the purposes of shared decision-making. Of course, it was an unfunded part of the ACA. In Oregon specifically, they've included it in the CCOs and part of the kind of Oregon Health Plan management. And for the Centers for Medicare and Medicaid Services, the meaningful use, if anybody's familiar with that, which are kind of these objectives that we need to meet in order to comply with CMMS services. It's one of the objectives includes patient-specific education and decision aids, which includes shared decision-making. So the first part, we're going to break down the elements of shared decision-making. And first, we're going to start with decision aids, because this is really where most of the research and content has concentrated. And we have a very specific definition of a decision aid, and it's more than just transferring information on a sheet of paper that has, even if it's in a variety of ways. So there's actually an organization called IPDAS, which is one of my favorite names. So the International Patient Decision Aid Standards Collaboration, and they do research on information sheets and decision aids that are put out by various organizations, and they rate them based on how much information does it include. Does it offer patients alternative ways of looking at statistics? So for example, are there paling palettes where they show the number of people that have certain things? Do they offer statistics in different ways of 1 in 3 versus 30%, things like that? But also in terms of helping patients explore their own goals and values as related to the decision that they need to make. And they rate them. So there's actual, at the end, I'll give you the website for where you can look these up. And the Ottawa Hospital Research Institute has their own patient decision aid, which is a general decision, and I'll show you that in a second. So decision aids, when they look at them in general for any population that they use it for, and they looked at these a lot for in the beginning for things like prostate cancer screening, breast cancer screening, or breast cancer treatment, lumpectomy versus mastectomy, and interestingly enough, knee replacement. And the Cochrane review of decision aids in general really shows that decision aids are successful in increasing knowledge. They increase one's accuracy of risk perception. So whether I'm overemphasizing a risk or underemphasizing a risk, for me personally, using a decision aid can help with that. It improves communication between providers and patients. It has been shown it's been proven to show that decision aids can help patients make choices which are in line with their own values once they define what those are, once they understand what they are. And patients then end up with decreased decisional conflict and the idea that there's this decrease in passive decision-making where they just allow things to happen. Where things weren't so successful or where it's inconclusive is whether or not it actually saves you time. We all have this idea that if I engage in shared decision-making, this is going to take a lot of time. We're going to have a conversation that's going to last for 45 minutes. And that's hasn't actually been shown to be true. The consultation lengths that they saw varied from 8 minutes to about 25 minutes, give or take. And so it can be a time saver or not. We don't know whether or not it actually decreases patient anxiety, which for our population here is actually quite significant. We have a lot of patients with increased anxiety. So whether or not using a decision aid and giving them all this information and making them go through this process of defining their values helps them or not is a question. There's also this question about whether or not it improves health outcomes. So not only do we not know quite how to define those health outcomes, but we don't know if we're influencing them by using decision aids. We don't know whether or not it helps with patient adherence in terms of whether or not they're doing what we want them to do. And we certainly don't know whether or not this decreases healthcare costs. So this is an example of the Ottawa Personal Decision Guide. So this is available online, and it's a very generic decision aid, which is, as you can see, it says, what decision are you facing? How do you feel about it? What are your options? And they ask you to rate it 0 stars to 5 stars. This is super important to me. This is not very important to me. And it's actually like a 5-page pamphlet that helps you go through it. Now, one of the things that they recommend is that you actually have a decision coach that helps you go through this, whether or not that's the provider themselves or part of the healthcare team. They see it as a team approach. They do this in the UK where they have the provider, the nurse, and a decision coach, which helps the patient go through this process. And this is up in the corner is the inventory decision aids where you can look up different decision aids that they've rated in IPDAS. So what about in maternity care specifically? Well, there have been a couple studies over the past few years about looking at primarily decisions around induction, external cephalic versions, VBAC, when to give birth, where to give birth, and prenatal screening options. And some in options for pain relief and labor, really about epidural, not really about anything else. And they found that, sure, okay, we've got some decrease in anxiety and decisional conflict, which is great. We've got some increased knowledge. There's an increase in the sense of informed choice where patients feel like they are making a more informed decision, and there's therefore increased satisfaction. But what we don't know, again, is has this influenced the final choice or the outcome? So for example, if we are interested in reducing primary C-sections, does using a decision aid actually help us do that? Or are women choosing to have a C-section based on looking at their decision aid? And that's something we don't know yet. This is from Canada. This is the Vancouver, British Columbia Midwives pamphlet. It's called The Power to Push. It's the best VBAC decision aid that I have seen. And part of the reason why this is considered a decision aid is because it asks women to rate their values. So again, this is how important is this for me that I know exactly what to expect from surgery, or I'm okay with having I really want to have a vaginal birth, or I want to know when my baby's going to be born, or whatever. And so this is more than just presenting information on a piece of paper about your risks and benefits of repeat C-section versus TOLAC. And one more thought about decision aids, and this is again no way an endorsement of this particular birth plan, but I see birth plans as decision aids as well. This is where the patient will tell me what they're thinking, what their goals are, what their values are, and then that can help me help them make decisions around what's best for them, what their goals are in terms of pain management, VBAC, TOLAC, epidural versus not, water immersion versus water birth. And so I probably am speaking to the choir and with this audience, but a lot of times birth plans are dismissed as a wish list, basically. And to me, it's if you dive into it, it's really a values declaration. So that's decision aids. So next we're going to talk about what we mean by a preference-sensitive condition. And this gets a little complicated because we work in maternity care where not a lot is certain. So a preference-sensitive condition is one where there is more than one clinically appropriate intervention or management strategy, each with its own benefits and risks, but which in its clinical outcome would be equal for the patient. So the easiest example of this that I can give you is an IUD insertion, or the choice between a Paragard or a Mirena for a person who has no risk factors either way. So they have nice normal periods. They don't have any risk factors in terms of they don't mind the irregular bleeding. If they were to do a Mirena, clinically, they could have whichever IUD they wanted, and which one they choose comes down to, do they want hormones or not hormones? Do they mind irregular bleeding or possibly heavy periods? That is a preference-sensitive condition. Which one we choose lies solely in the determination of what value is more important to that person. So when talking about shared decision-making in maternity care in terms of it as a preference-sensitive condition, there's just a number of papers that have been written on this. We talked about listening to mothers 1 through 3. There's the Maternity Shared Care Shared Decision-Making Initiative, which have put out a couple of statements around shared decision-making in maternity care specifically. The consensus statement on normal physiologic birth, and then ACOG and ASAM have some position statements as well when they discuss shared decision-making in maternity care. Part of the reason why shared decision-making is difficult in maternity care is due to this idea about decisions that need to be made quickly. We all know this if we've done prenatal care. We know this if we've been in any sort of situation where decisions need to be made, and sometimes decisions need to be made in a timely fashion where we perhaps don't have enough time to go through exactly and take 20 minutes to talk about all of our options. But it's still possible to do it. It's just a limitation, but there is definitely a way where shared decision-making can happen on the maternity ward, especially in these types of situations. But it's just to say that not very much research has been done in the interpartum setting because it is so difficult. And this brings up the idea of uncertainty and shared decision-making, and uncertainty in maternity care. So there was an ACOG practice bulletin that came out gosh, I think probably at this point it's been about 7 or 8 years, that looked at all of the recommendations that ACOG publishes in their practice bulletins in terms of what's category A, where it's absolutely recommended, what's a category B, where it's based on expert or based on pretty good evidence, or category C, where it's based on expert evidence. And they show that basically only about 20% of their recommendations are based on really good evidence. And so we, especially, can only speak to for myself in maternity care, we live often in a state of uncertainty. I don't really know what is the best evidence in terms of, let's bring up gestational diabetes testing. We know that it's good to test. We have evidence that testing for diabetes is appropriate. What's the best test to do it? What's the best cutoff? We don't have an answer for that. And so how do we counsel women, and how do we participate in this process of shared decision-making with this uncertain knowledge? So we have gaps in our medical knowledge. We've got conflicting evidence. Do we believe the ARRIVE trial when it says that induction of labor at 39 weeks is appropriate for certain populations? I don't know. Sometimes we as providers feel like we have an obligation to offer patients everything. So just because it's my colleagues down the hall are offering women of advanced maternal age induction of labor at 39 weeks, does that mean that I have to offer it too? How do we talk about that community standard of care as an uncertain aspect in shared decision making, which makes me anxious? So now I need to present myself as an expert in this field, while also acknowledging that clinical uncertainty can lead to anxiety. And then there's this idea, which is another favorite of mine, which is the subjectification of objective probabilities, which this really means, how do you take this population-based data and apply it to the person in front of you? And this is what we run in, that I find many times with my patients who are of advanced maternal age, where population data says you have a chance of 1 in 1,000 being 35 and a multiple of having a stillbirth at term. So what does that mean for you right now? I can't tell you. I can't tell you what your specific probability is. Although, as one of my former colleagues used to say all the time, if it happens to you, if stillbirth happens to you, it doesn't happen to you 1 out of 100 times, it happens to you 100%. So it's a very difficult idea of applying this data to an individual and how you do that well. And then there's also this idea of over and under prediction of risk. So risk communication and understanding of risk is a skill in and of itself. And often we can overemphasize the risk of something where, you decided not to do glucose testing in your pregnancy, which means that you have got an increased risk of having a big baby because you might have diabetes, and therefore we're going to do an induction at 39 weeks and we're going to have shoulder precautions. Or I can underpredict it. I can say, well, yeah, you don't, your risk is really minimal. You eat a healthy diet and you exercise, and your EFW is 8 pounds. So I'm gonna de-emphasize the risk for you. So how you communicate these things, to me, shared decision making offers a perfect vehicle, because it is a process and it's a conversation between the patient and the provider, the woman and the midwife, to allow for this type of uncertainty in the process. Sorry, that was a lot of theoretical right there. But what we're gonna move on to, what do we mean by a clinically appropriate patient? So who are we really talking about when we're talking about applying shared decision making? And what do we mean by what are we sharing? So a clinically appropriate patient is exactly what it sounds like, right? It means that a person who meets the clinical criteria for the intervention that's proposed. And sometimes that means that you are seeing people who want something that they don't get to have, maybe for certain reasons, maybe for good reasons, maybe for not so good reasons, but it's something that you need to take into consideration, whether or not you then even can proceed with offering them that intervention. And then it also comes into, what are you exactly sharing? What are you as a provider sharing with women? Do you share your biases? Do you come right out and say, you know what, I really don't like the Paragard. I much prefer the Mirena. The Paragard, too many women complain about it. I think you should get a Paragard because it's a much better bleeding profile. I've had students come to me and say that they've heard their preceptors say this very thing to women. So are you upfront about it? I will tell you personally, the only thing well, not the only thing, but one of the things I'm very upfront about is my bias towards vitamin K shots for newborns. So I have a population here who like to decline a lot of interventions for themselves and their newborns, and vitamin K is one of them. And I try to present an unbiased and be open in our conversation. But if they really come in and they ask me about it, what do you think, Michelle? What should I do? I will tell them that one of my experiences as actually in nursing school was a baby who died who hadn't received vitamin K. And so I have a very personal response to it. How much do I reveal of that? That's a question. Do I reveal my preferences, that I feel more comfortable doing a Mirena insertion than I do a Paragard insertion because the mechanism is different? How much do you expose of that? And what are you really asking from the women? What are we asking them to share with us? We're talking about their perception of their risk. We're talking about their values and goals and their risk tolerance. And sometimes they don't know what that is. Sometimes part of shared decision-making is, helping them define those things, because sometimes you don't know what your value is in that situation until you're forced with just that choice in that situation. There's also this idea from the ACNM, and this is not in the obstetric literature, it's in the midwifery literature, this idea about shared responsibility. And this is from the ACNM Code of Ethics. I've seen this idea also in many of the, in the MANA documents and in the International Confederation of Midwives documents. So this is, to me, a midwifery concept about sharing responsibility with the women, which is all about going through this process to make an informed choice, come up with a plan of care, and each of us accepting responsibility for the outcomes of those choices. I think we need to do a lot more research on this because it's a fascinating concept to me, but I'm already working on my PhD, so one of you guys out there with your DNPs, your turn to kind of take that on. The other thing that we need to look at is, what skills do we need to have in order to be successful in this process of shared decision making? And this is a really interesting study that was done in 2013, where they held a working group for 3 days where they tried to come to consensus about what specific skills should providers have in order to be successful in shared decision making. And basically, they had no consensus. They could not reach an agreement as to really what specific competencies should we have in order to be able to do this, which is hard. But what came out of it also was this idea that we should know how to communicate risk, which includes this concept of uncertainty and how to be accurate and effective in our communication about risk. And also we should have, surprise, surprise, we should be human beings. We should have some relational competencies. We should know how to talk to people. We should know how to listen to people, and we should know how to assess their literacy level and how much they're able to understand of what we're talking about. Yeah, risk tolerance is huge. My risk tolerance is very different than my colleagues and very different than the women's. And risk tolerance actually, especially for me in obstetrics, changes over time. This is from the same Delphi study that was done in the Netherlands on shared decision-making in interpartum care, talking about a more detail of what type of provider skills women are looking for. And, they want a relationship. This is not a surprise, right? They want open dialogue. They want you to have experience in the evidence, to be able to talk about the evidence in an appropriate way. Women want you to have them participate in the decision making and support deliberation when that's available. But they also talk about this idea of prenatal preparation for things that might need to happen in case of quick decision making, and debriefing afterwards. So even if decisions need to be made quickly and it may not seem that full consent or shared decision making is happening in that moment, the opportunity to come back around and do debriefing mitigated that fact. So a couple kind of frameworks that put all of this together for you. In the UK, they were doing this program called Making Good Decisions in Collaboration, or MAGIC. And they broke all this down into what they call choice talk, options talk, and decision talk. And this is really kind of a framework for how you can actually, as providers, do this. So choice talk is really about talking about the idea of choice, what choices you have to make. Options are checking their knowledge on what they know already, what they don't know, talking about the options and the risks and benefits, offering decisional support. And then decision talk is talking about what's important to them, what are their preferences, making sure autonomy is being respected, clarifying decisions, and making sure the team is aware as well. So one of the things in terms of choice talk that's really important is that you actually assess the person's desire to participate in the decision making. So for example, I took care of a lovely woman from Poland, and she was being induced for advanced maternal age. And I had admitted her, and I had checked her cervix, and she was typical multip, kind of like 1 to 2 centimeters, and kind of favorable, but not really. And so I was all ready to have this conversation with her about the different methods of induction and what we could do and what we couldn't do, and the risks and benefits of both, and what was important to her for that day, and what her goals were. And I was maybe like 5 minutes into this conversation, and she looked at me. She was like, "Michele, I'm from Poland. I don't want all these choices. You tell me what's best for me right now." So that was a good lesson for me in not making an assumption of how much she wants to be a part of this conversation, because some people don't want or can't manage the anxiety of making these kind of decisions. And so managing that in the beginning is critically important. This is an example of some options talk. So again, this is about providing evidence-based and accurate information. The examples that are here are both from the MAGIC website, and then the ones about injections were from, I adapted this talk to talk about the ARRIVE trial and adapting shared decision making to the ARRIVE trial. So this is about showing a possible decrease in C-section for some women in certain circumstances. So what is important to you in terms of these options? And then the last one, of course, is decision talk, which is moving towards the decision. But also recycling through the decision. So the decision doesn't need to be made where, if you're talking about a woman who is choosing repeat C-section versus VBAC in the antepartum time period, just because at visit number 3 she said, "You know what, I think I want a VBAC," doesn't mean that you don't circle back around on visit number 5 and say, "Hey, we talked previously about this. Are you sure this is what you want to do?" And that's what they talk about in terms of screening for decisional conflict. This is kind of making sure that you're just kind of going back to the bigger picture and saying, do you feel sure about this? Do you feel informed? Do you understand your risks and benefits? And then do you have enough support to actually make this decision? So it's another nice acronym to remember that. So you're checking back around with people. This is one more model of communication. So this was really developed in terms of how to teach. It was a communication tool developed for medical students and residents to talk with patients and to talk with their attendings and how to give report. And it's was developed to really bridge some cultural differences and trust issues. It's a really great article that they wrote in 2010 that describes it, and I highly encourage you to read it. But the respect model basically talks about the same things that the consensus group talked about in terms of creating an environment where shared decision making is possible and honored, having an attitude of respect, finding out their understanding first about what's happening with them, and listening to how they want to participate in their choices, what's the impact of their illness. Yep, I'll go back. Here's the name of that article right there, Mostow. The name of the article, sorry, I don't have it on me, but that's the citation right there. And I think Janelle's going to have the slides for you guys anyway, so you'll have all this. Yeah, Slides will be available. Perfect. And addressing, showing empathy, talking about their concerns and their fears, which again moves into their goals and their worries, and their values, and then team building and trust. So if you like, I have a couple more tools that I can show you, but we've talked a lot about how shared decision making as this process is to me, a really intimate conversation between women and their provider, their midwife or their provider, about how to engage in decision making that is respectful and that honors each person's autonomy and opinion and evidence. And so when you are in that small area of shared decision making, it's easy to say that this is going to kind of fix the problems of mistreatment for women on the labor floor, mistreatment for women in obstetrics in general. But really, to me, this is just such a focused view where it's such a larger problem that we need to address, because shared decision making is a part of overall respectful care for everyone, and it's a part of a culture of safety and healthcare in general, especially in maternity care. And then it is the global right to dignity that we need to honor. So even though we've kind of focused on this, it's important to remember that shared decision making is just a small piece of the larger pie, and looking at respect and maternity care. So that's what I have for you guys. I'm gonna take a sip of coffee for my voice.
Thank you so much, Michele. This was a wonderful presentation, and we're going to start letting students put questions, or not everyone is students, but if people want to put questions in the chat box, then I will attempt to give them to Michele. And I had written down a couple as we were going through. A couple of students, Renee and Elaine, both commented on the problem of when they present the plan to the patient and ask if they agree, that the patient will say, well, why are you asking me? Don't you know? How do we approach that when the patient just wants to be told what to do?
That's a great question, and that's to me a challenge as well, because I had that happen to me early in my career, where it was the expectation that I would just tell them what to do, and it really hurt my feminist heart at the time, where I was like, but this is your choice and this is your decision and this is your decision. So to me, in that situation, I usually kind of explore what's important to them. I ask them in that way, like, well, what's your goal here? What's important to you? And then I say, well, based on that, I'm hearing that they don't want to make the decision. And there's a lot of reasons why people don't want to take that responsibility of making that decision, which I also find fascinating, where sometimes they want you to make that decision so they don't have to, and they don't have to take on the burden of that decision. And I try to be aware of if that's what's happening. And then I say, it sounds to me that this is what's important to you, so let's do this. But I try to reflect it as either a goal or a value. Does that make some sense?
That makes sense to me. I think that's great. And another question here came from, how would you approach shared decision making in a situation such as Category 2, almost Category 3 fetal heart tones, and need to do an emergent forceps delivery?
Yeah, that's a great question too. And I think that some of that is antenatal preparation, in terms of this idea that emergencies happen. So having conversations about in some childbirth education, and I struggle to strike a balance of not fear-mongering and being like, birth is, crappy and you can have all these bad things happen to you, but at least acknowledging at some point that sometimes decisions need to be made quickly. And so clear and concise information about your baby being in fetal distress, or your baby being in distress. This is what we're seeing. This is what we would like to do. We need to act quickly. Can we do that? I've seen that work well, where things are clear and calm and concise, And I've also, I mean, we've all seen the quote unquote, pardon me, the shit show that happens when those things happen. But usually that's because there's lack of clear leadership or communication. And then going back and debriefing. Now, remember, in those situations, at least for me, if she says no, you can't do anything until she says yes. And that gets into the, how do you manage, refusals in those situations without being coercive. I think it's again, that balance of like, you don't want to say that your baby's going to die unless really it's imminent that it's going to happen. I think we overuse that phrase because it's easy to do it. It's easy to say, well, if you don't do this, you've got a chance. If you don't stay and be induced with your AFI of 3, then there's a good chance that your baby's going to die. I think that's a very different situation than saying your baby's heart tones are in the 50s and they've been in the 50s for the past 2 minutes. We need to get this baby out now because your baby might die. And us taking on that responsibility to understand the difference between those two. That's my opinion.
Excellent. Daniel Steck had a question. Well, he said he has using a shared decision-making tool that I created for my STI testing DNP project has been very impactful for patients. So I guess that's a comment, not a question.
Cool.
But yeah.
An STI?
Yes, an STI tool for testing.
That would be really interesting to see. Okay, yeah.
Yeah. Then Megan asks, can you give an example of shared decision-making when an unmedicated woman is giving birth and delivers the head and then clenches her legs together and begins to scream and crawls back in the bed? It's hard not to have the nurses help her with her legs to let the baby out.
Yeah.
After gently trying to talk to them about opening their legs and letting the baby out because this is the end.
Yeah, it is. Sorry, I'm flashing back to this many times that I've been in that situation. I think, that is such a hard situation to be in. And sometimes, to me, the way that it's been most successful, honestly, that in my experience, is 2 things. One is not forcing things, like if she's crawling up the back of the bed, there's only so far she can go, and letting her legs clamp down. We'll deal with the repair afterwards. But I think having someone be able to be in close eye contact with her, where it's usually either a family member or the nurse can be up there and just kind of get with her and get in that space with her, that usually is enough to do it. Or the baby just comes out anyway and you just follow her where she goes. And that's as long as you're not allowing the baby to drop on the floor. Or I did have one woman actually she had almost had one leg slung over the top of the bed trying to get out, and her husband blocked her, and then the baby slid out onto the bed. But those are horrible situations to be in, and you're absolutely correct. How do we manage those very difficult, dramatic situations when things are happening? I think we can do it without forcing women's legs open and slapping them.
Well, and even in a situation I've seen many times, the woman is not out of control, but someone is forcing her legs farther apart. And I always go back in memory to a woman with MS that I took care of, and she was unable to open her legs because of her MS, and she delivered on her side in fetal position with her knees together but pulled up toward her chest, and it worked beautifully. So why do we need to force the legs apart?
So the provider can deliver the baby. That's, I mean, when it comes so that we have control over it, I think that's, I see that what I see when that's happening is fear in providers about the woman's lack of control and their lack of control over what's happening with that baby and that delivery. I think that's why people force women's legs apart. So I disagree with that. Yeah.
Yeah, we have a couple of comments kind of similar. One student says, it's hard to have a shared decision-making conversation about something like an episiotomy that's being done for fetal distress. I can only hope in this situation that the trust has been built to the point to that point is enough foundation for the client to consent. The debrief is key, otherwise it feels terrible. And then another comment, similar, shared decision-making is great, but in some situations, time is of the essence.
That's it. All of those comments are exactly right. And it's not just in maternity care. I think episiotomy is actually a question, something that we talk about a lot prenatally. Often women in their birth plans talk about they don't want an episiotomy, or I'll bring it up as part of talking about birth plans. And that gives me an opportunity to say, here, these are the times when I would cut an episiotomy. It's this, this, and this, or if this happens. And so if we're in that situation, one, you'll probably know beforehand that the heart tones are kind of squirrely anyway, and we're kind of worried about it. And two, I'm going to ask you before I do it, and I'm going to say, I'm sorry, we are there, we need to do this. And we've already had this conversation. So that's part of the anticipatory guidance, and then it's debriefing afterwards.
Okay, another student says, I feel like shared decision-making should also include family or caregiver. Could you talk about that briefly?
Yeah, I think shared decision-making should include family or caregiver as much as the woman wants them to. So sometimes that's a lot. So we talked a little bit about the woman deferring the decision to the provider, but often women will, or people in medical decision will defer it to their family member or to their partner. And again, my feminist heart kind of squeezes a little bit and misses a beat when my patient kind of consistently turns to her partner and says, what do you want me to do, or what should I do? Oops. So it's absolutely they should be involved, because again, we're talking about a woman in her context, and her values are part of being in that context.
Another comment from Renee, I have been really trying to use the expert training to get my patients used to being in the driver's seat. The idea that they are ultimately responsible for their health, and I am coming alongside so they can make informed choices. And then Charnel asked a question. Do you believe it has to do with cultural practices and expectations if a patient wants to make her own decision or wants the provider to make the decision? I find that most of my Middle Eastern patients want me to make the decision for them.
Yeah, I think it's absolutely cultural, and I am in no way an expert on different cultures and how they make decisions. But my experience of has been primarily in Chicago, in the Latina population, and very much, there were many women who were like, well, doctor, what do you think I should do? What do you think should happen here? And it really took me some time to understand what they were asking, and to try to make a choice and proceed with an action that seemed to be best aligned with what they were wanting from our conversations. But it's hard when they just say, yep, it's you're the doctor, you're the provider, you're the midwife, you are the one who should be making this decision, not me. And then you got to make a decision, because an action needs to be taken. And then you cycle back around and ask them again.
Okay, and we have a question about the mother's autonomy in decision-making scale by Vadam et al. 2017. The emphasis in the scale is measuring the woman's ability to lead decision-making during maternity care. What do you think of this?
Yeah, I actually haven't been able to really look into that very much. I appreciate the question.
Yeah, that sounds interesting.
Yeah.
I would definitely like to look at that too. Then let's see. In most situations, do you typically have them fill out a physical shared decision-making form and then review or go through it in a conversation?
No, usually this is all happening in conversation, honestly, and not any forms. The only decision aid that we have is on VBAC, which I give to people to take home and read and talk about with their partners and come back and talk about with us. And then I use a birth plan. But most of this is just for our practice, we're just doing it in conversation. And then I'm documenting in the notes about our conversation. And it to the point where I will say in my notes, engaged in shared decision making regarding induction of labor or whatever. But we don't have a specific form.
Okay, and then number of comments from people about the legs closed versus forcing them open issue, and people saying, it becomes challenging when the nurses are yelling at the patient and it's all out of control, and many people saying that a side-lying delivery without the legs opened can be done.
Yeah, I think that's a culture in your unit, right? That's a culture at your hospital that people shouldn't. It drives me crazy when people start yelling. But that's me.
And then a question from Michele. Do you find that when you use shared decision making as your norm, that when these emergent cases happen, women have more trust and feel less like they need to be part of the decision?
That's my hope. I think that depending on the circumstances and depending on really what their expectations were, which sometimes they don't realize how much they expected things to happen a certain way. It's my hope that the trust is there. I find that it's the debrief afterwards that brings on the trust, or not. That's when I've had people be like, you were mad, express their anger at what had happened with the decisions. So that's my goal, is that there's more trust.
And then a final comment here. Anna says, I worked in a hospital with all OBGYNs and no midwives. Shared decision-making was not their strength. My question would be, do you have any suggestions as to how we can promote this among providers that are not interested in doing this?
That's a culture change, and it's an expectation, right? That you have to start. I just started using those phrases with our students and in front of the residents when we do board rounds. So I talk about how I engaged with shared decision making with this patient about this issue, and this is what we have decided to do. So it begins in the same way that evidence-based medicine has kind of become the more accepted route of decision making clinically. Part of it is peer pressure, right? If you're not conforming with it, so but it takes like any other culture change, it takes leadership, and it takes calling people on whether or not they're doing it.
Well, thank you very much. We have many comments here, too many to read, that people saying thank you. They really appreciated what you said. And let's see, there's a final question here. It looks like, don't you think that culture change will occur when the staff consistently see, it scrolled up, I couldn't see the end, when they consistently see the good outcomes over time?
Yeah, I think that part of that is changing what we are defining as a good outcome, because you can have shared decision making that ends in a poor outcome, but everyone is still valued and respected, and that is a good outcome. And we need to change our focus to those as well, because I think we're so fixed on the did she have a vaginal delivery? Well, then she should be happy with her care, right?
Yeah.
To put it bluntly, yeah.
Well, thank you so much for a very wonderful presentation and lots of comments thanking you. So we hope that you'll come back again sometime, and we appreciate what you've given. Thank you again.
Great. Thank you so much for inviting me. I really appreciate it and have fun.
Thank you, Michele. This has been just wonderful. All the students are just like, we've never had this kind of response. This is really just great. Thank you again.
Thank you so much, you guys. Take care.
Thanks, everyone, for attending, and have a good evening.
Good night, everybody.
Good night. Thank you.